Tissue's response to injury. Injuries can occur from different events, either large or small. Acute injuries can occur from rapid onsets resulting from macrotraumatic events, such as the picture on the left of the University of Tennessee football player. As a side note, this football athlete, the one in the orange jersey, has a very large macrotraumatic event injuring his knee. His entire lower leg is bent the wrong way. This resulted in a fracture and dislocation of the knee. This type of injury frequently happens from one incident, and the patient can usually tell you exactly what happened, when it happened, and how it happened. We can also have injuries which occur over much longer periods of time. These are typically referred to as chronic or overuse injuries. Chronic or overuse injuries develop over a period of time from a series of microtraumatic events. Many of us have experienced low back pain, such as the pain exhibited in the picture on the right. Many times you cannot distinguish exactly when it started hurting or what brought on the pain, but you just know it hurts. Approximately 80% of people will have experienced low back pain in their lifetime, and for the majority of us, it will eventually get better over time and will just resolve itself. However, that can't be said for all chronic injuries. Time does not always necessarily heal everything. So which one's worse, acute injuries or chronic injuries? The simple answer is if you're the one in pain, they both can be terrible. Acute injuries hurt immediately because of the large force and traumatic event. We know exactly what happened, how it happened, and why it happened. Chronic injuries are typically a little less painful, but the pain tends to last for a much longer period of time. That pain typically wears on individuals. They can be very difficult to treat, and it's hard to determine exactly how it happened or why, so treating the cause of the injury can sometimes be difficult. The way we treat these two types of injuries can vary greatly, but it's something we can continue to discuss and explore during this course, as well as other courses during your program. It's also important to explore how injuries happen. We'll start with tissues. This could be a muscle, a tendon, a ligament, a bone, a joint capsule, or other types of tissue. When forces are applied to the tissue has one of two responses. It can either adapt to the forces that are being applied to it, or it can fail. This is known as Wolff's Law. If the tissue fails from the force that is being applied, then we have a disruption of the tissue, which is how injuries occur. So every time an athlete, such as a football player, gets hit during a game, why don't they get injured? They have muscles, bones, tendons, ligaments, and all other tissues. And all of those tissues are being subjected to forces. So why don't they get injured more often? Well, there are several factors that can contribute to the risk of a force resulting in injury. First, the magnitude of that force. The magnitude of the force has to do with how large the force is that you're being struck with. For example, you might survive being run over by a bicycle a little bit easier than being run over by an automobile because of the size of the force. The car has much more force potential and therefore could have a greater magnitude of the force. In addition, the car can also travel at a greater rate of speed and is also much heavier, which allows it to create a larger magnitude of force than does the bicycle. Second is the movement arm of the force. The further away from the access point in the human body, this is typically the core, the less force is needed to injure structures. Third, the direction in which the force is applied. Typically, a perpendicular force, or a force that is applied at a right angle from the impact, has the greatest amount of force. If a ball is thrown at you and hits you directly from a 90-degree angle, it hurts a lot more than if it glances off of you from a much shallower or a much deeper angle. Next is the magnitude of the stress produced. The stress produced by the force depends upon the surface area over which the force is spread. For example, a football athlete or other padded sport athlete wearing shoulder pads, when they're hit, the force is distributed over the surface area of the pads. If an athlete was not wearing those pads, the force would be directed over a very small area and could increase the chance of injury. Last, the properties of the tissue. Muscle, ligament, tendon, and bone all react differently to forces and stress. Muscle is a lot more elastic than bone and thus can deform and retain its original shape. Bone can withstand large amounts of force, but it does not have a lot of elasticity, which is great for holding us up, but is really bad for when the force exceeds the bone's capacity to withstand it. The mechanism of injury, or MOI, is a common abbreviation you will see within many notes. To understand the mechanism of injury, we will need to define different types of forces. First, compression forces are axial loading that produces a squeezing or crushing effect. The weight of the human body constantly produces compression on the bones that support it. If you think of your spine, the discs are compressed between the vertebrae every time you take a step or move or even stand. Tension is an axial load in the direction opposite that of compression. Tension is a pulling force that tends to stretch the object to which it is applied. This may feel good to start. Pulling on tissues is a common practice of massage and physical therapy. However, too much tension will disrupt the tissue and can actually result in tissue separation. Tension used to be used as a form of torture. We often call this placing people on the rack. Oftentimes, they would place tension on the arms and legs until the joints actually separated, and the soft tissue did too. Eventually, the person was actually literally pulled apart. Shearing forces act parallel or tangent to the plane passing through the object. When a person stops quickly and the muscles of the quadriceps and the hamstrings are not strong enough or do not activate quickly enough, there is enough force for an anterior cruciate ligament or ACL to actually be sheared off of the femur by the tibia. This is referred to as a non-contact ACL injury. So if you've ever been watching a sporting event and you see somebody and it looks like they're running all by themselves, all of a sudden they fall to the ground and clutch their knee, there's a good bet that this injury has occurred. Bending are forces that cause one side of an object to come together. Every time you bend over to put on your shoes in the morning, you're creating a bending force in the spine. Now, the spine is okay with this bending force, but what would happen if this occurred in the long bone of your forearm? The forearm probably wouldn't like it and would either have to adapt to it or would end up in a fracture. Torsion forces are rotating in opposite direction from each other. The body does not respond very well to torsion forces. When teaching individuals how to lift properly, the technique is always to lift with the legs, keep the object as close to the body as possible, and move the entire body as a unit. Do not twist at the spine. Twisting results in those torsion types of forces, and it does not take much torsion, especially in the spine, to injure body tissues. Combinational or combined forces are any combination of the aforementioned forces. This could be torsion with a compression, or a shear with a torsion, or any other combination. Combinational forces typically result in very complicated injuries. Our muscles are like rubber bands. We see in the picture a rubber band being stretched between the thumb and the first finger. Our muscles act in much the same fashion as this rubber band. We can stretch our muscles within a certain limit and they will retain their shape just like the rubber band. But what will happen if we extend our fingers just enough with this rubber band? Eventually, it will break. Our muscles have the same type of property. When this load exceeds what is called the yield point or the elastic limit, our muscles can no longer keep their elastic shape. Eventually, the muscle tissue will fail and become what is called a plastic, which means it no longer retains its elastic type of property. Our next section of the lecture is classification of injuries. We'll go through each of these in a little bit more detail, including soft tissue injuries, which includes skin injuries, muscular tendon injuries, joint injuries, bone injuries, and nerve injuries. The healing phase and process is remarkable and complex. It is also susceptible to interruptions due to local and systemic factors, including moisture, infection, local maceration and age, nutritional status, body type, as well as other environmental factors. There's a common misconception that inflammation is bad. Inflammation is good and necessary. We need inflammation in order to have healing take place. However, we can minimize the signs of inflammation, and that is beneficial. The two biggest things we can minimize are swelling and pain. If we eliminate inflammation, it can result in prolonged healing. Many people equate swelling with edema and inflammation, but these are not all the same. Swelling and edema occur during inflammation. Edema causes swelling, but swelling occurs from other sources as well. All edema causes swelling, but not all swelling is caused by edema, so things get a little bit complicated. Ice can help decrease inflammation, but inflammation is necessary for repair. This misconception occurs from the fact that swelling needs to be minimized. Swelling and inflammation are therefore not the same thing. The most common signs and symptoms we see for inflammation include redness or rubor, swelling, also known as tumor or edema, local heat, also known as calor, pain or tenderness, also known as dolor, and functionalisia or loss of function. Each of these signs will occur in some degree when tissue is injured and the body responds with the inflammatory process. The phases of inflammation. Inflammation consists of sequential and overlapping events. We first have an injury. This injury results in ultrastructural changes. Chemical mediation occurs, which results in hemodynamic changes. We see metabolic changes, permeability changes, leukocytes migrate to the area, and phagocytosis occurs. There is a primary injury. This is the occurrence that impairs the tissue structure or function. In most sports, this is caused by either a macro trauma or a micro trauma. The macro trauma is usually a large impact or contact. This is what we typically refer to as an acute injury. A microtrauma is more what we refer to as a chronic injury. This is due to overuse, cyclical loading, or even friction. There can also be some other types of injuries, each of which result in the same basic inflammatory response. These other causes of injury can include physical agents, which may include trauma, burns, and radiation, metabolic processes, which include hypoxia, biological agents, including bacterial, viral, parasitic, and infections, chemical agents, including acids, gases, organic solvents, and endogenous chemicals, which include normal secretions, in abnormal locations, such as gout, or in increased quantity in a normal location, such as stomach ulcers. The magnitude after each phase varies according to the causative of the agent. For the ultrastructural changes, these occur as a direct result of the trauma, the primary injury, and indirectly as a result of the hypoxia, the secondary injury. The secondary injury occurs in cells adjacent to those that undergo the primary injury. Lysosome supplies chemicals that digest foreign material within the cell and gets rid of it. If the membrane of the lysosome ruptures, its contents will attack and digest other material. Chemical mediators such as histamine, bradykinin, pro-inflammatory cytokinins, and anti-inflammatories are activated by ultrastructural changes. These chemical mediators signal to the rest of the body that cells have been damaged, which sends out a distress call to the rest of the body to respond. These mediators modify and regulate the rest of the inflammatory response that neutralize the injury and remove cellular debris so that repair can take place. Chemical mediators are somewhat like police officers that come into a site of an accident or an injury and direct events until the accident or the injury is cleared up. We have hemodynamic changes that occur. The arteries dilate, increasing the blood flow to the injured area. However, blood vessels that were previously inactive open, so blood flow through individual vessels decreases. This slowing of the blood flow is necessary so white blood cells can move to the margins. In these hemodynamic changes, we have inactive blood vessels, such as in Figure A. In Figure B, we have open blood flow to the injury to flood the area with blood and decrease the rate of blood flow in the injured vessel. These steps allow leukocytes to move from the center of the vessel to the walls to slow down blood flow. These hemodynamic changes and leukocyte migration. The leukocyte moves to the margin of the blood vessel. It then sticks to the endothelium, also known as pavementing. It moves over the endothelium surface and finds an endothelial gap. It passes through the gap and leaves the vessel. The leukocyte then moves about in the tissue. Leukocytes stick to the blood vessel wall through adhesion molecules. The leukocyte migration occurs through the gap in the blood vessel wall towards the increasing concentration of cytokinins. This metabolic change, the sodium pump actively moves sodium out of the cell and a lesser amount of potassium into the cell. The energy necessary to drive this process is supplied by breaking down the adenosine triphosphate, also known as ATP, into adenosine diphosphate, ADP, and free phosphate. This results in an increase in sodium concentration in the cell and organelles, an increase in water in the cell. The cells swell and burst. We have an increase in the intracellular acidosis, also known as lactic acid. The lysosome membrane ends up failing, and lysosome digests the cell. There's also a change in the permeability. Histamine and bradykinin increase the permeability of the small blood vessels. The endothelial cells contract and pull away from each other. Gaps are left through which the white blood cells can move out of the vessel and into the injury site. White blood cells then adhere to the endothelium or the vessel wall and/or to other white blood cells. White blood cells move out of the vessel by squeezing through the endothelial gaps. Neutrophils go first, and then larger macrophages follow. Neutrophils, the top, and the macrophages on the bottom are the most common leukocytes. Because neutrophils are smaller, they migrate out of the blood vessel first, but they soon die and add to the cellular debris that is cleaned up later by the macrophages. Neutrophils travel fast and arrive at the injury site first. They provide the first line of defense. When they die, they release chemical mediators that attract macrophages. The death of the neutrophils results in a large concentration of chemical mediators released by the cell. Macrophages are long-lasting and they're the second line of defense. They release potent enzymes that may destroy connective tissue, thus potentially adding to the secondary injury. They release chemical mediators that may prolong inflammation. They can also release factors that aid in healing. Macrophages secrete proteins that are important in the defense mechanism. Phagocytosis is the digestion of cellular debris and other foreign material into pieces small enough to be removed from the injury site. Unfortunately, we can also end up in what is called chronic inflammation. This occurs when acute inflammatory response does not eliminate the injuring agent. The tissue is not restored to its normal physiological state. This involves the replacement of leukocytes with macrophages, lymphocytes, and plasma cells. As inflammation persists, necrosis and fibrosis prolong the healing process. Granulation and fibrotic tissue both continue to develop within highly vascular and loose connective tissues. The cause for the shift from acute to chronic inflammation is unknown. However, it can be typically associated with overuse or overload events and with cumulative microtrauma to a particular structure. This can be a result from microtrauma, but it does not always necessarily involve an inflammatory reaction. For example, a clinically diagnosed Achilles tendonitis and patella tendonitis in which there is no evidence of an inflammatory reaction. This can also occur with a structural disruption and microvascular damage that can occur. This can cause pain and other symptoms before the classic inflammatory process is set into action.